Thank you. Hello and welcome, everyone. What a great pleasure it is to greet you all to this third and final ICMLF hosted CML discussion, or at least final for this year at least. Okay, so what a great team of experts we have today to lead this discussion on challenging scenarios. So I'll start with our international experts, and it's a great pleasure to introduce Dr. Kendra Sweet and Assistant Professor Vamsi Kota, both of them from the USA. So Dr. Kendra is a well-known hematologist from the Department of Malignant Hematology in the Moffitt Cancer Center, Tampa in Florida. And Kendra is a great friend of the International CML Foundation. It's lovely to have you here today.
Thank you for having me.
Assistant Professor Vamsi Kota is likewise preceded by his reputation. He is from the Bone Marrow and Stem Cell Transplantation Program of the Georgia Cancer Center in Augusta, Georgia. Wonderful to have you on board, Vamsi. And like two of our previous experts, Kendra and Vamsi are not only great physicians, they are intrepid adventurers too. They both summited Mount Kilimanjaro, Tanzania in 2019, raising funds for CML research and physician support through the ICMLF Climb for a Cure initiative. And believe it or not, they've both put their hands up to climb for a cure again this year, this time heading to the Nepalese Himalaya. So I'll send a link around to everyone in my follow-up email. I hope you'll check it out, and you never know, maybe some of you will join them on their next Climb for a Cure, wherever that might be. Moving on, our Latin American experts today are Dr. Rafael Hurtado Monroy, who heads the hematology department and the CML clinic in the Hospital Ángeles Pedregal in DF in Mexico. Rafa is another great friend of the International CML Foundation, and we're super grateful to him for all of the time and effort he puts into everything he does for us. And to complete the team, we welcome Dr. Virginia Abello Polo, a leader in leukemia, lymphoma, and myeloma from the Center for Cancer Treatment and Research in the Luis Carlos Sarmiento Angulo Foundation in Bogota, Colombia. Welcome, Virginia. It's a real privilege to share this platform with you today. So we have 7 cases that are ready to go that exemplify a whole range of challenging scenarios. Rafa and Virginia will alternate with each other in presenting the cases. Kendra and Vamsi will respond, and then all 4 experts will discuss these challenging scenarios as they arise. We'll take questions and comments from you, the audience, as they arise, but we're also going to try to keep to 10 minutes per case to make sure that we have some time for a free discussion at the end. So, Virginia.
Oh, well, it's nice to see everyone here, a lot of friends in the CML community. So I'm going to share this case first. The next one, Arlene, please. So this is a very difficult case. It's a 68-year-old man. He's an orthopedic surgery next door neighbor in the clinic. So it makes me, it's the first challenge. No, it's a doctor. And he has had various episodes of thrombosis, deep vein thrombosis, pulmonary embolism. He's anticoagulated with Xarelto, and then he has another thromboembolic event. He's not very regular with his drugs for anticoagulation. Then he had a portal vein thrombosis. So he has at least 4 events. Coronary artery disease in September with an acute myocardial infarction in September 2020. He's obese and he has type 2 diabetes. So he's, at the time I knew him, he was in Xarelto, Etaloxoc, metformin, and aspirin, and he's fully active, works 10 hours a day. It's a surgeon, so he's every time in the OR. And in February 2021, he comes to me with this leukocytosis. I start the studies. He has acronym myeloid leukemia. You see the studies there. And he's in chronic phase, 1 to 2% of blast in the bone marrow. So he's a high-risk patient, so-called intermediate, Eutus low, and HASPUT high. So I start him on dasatinib, 100 milligrams a day. in March 2021. And that's how he behaves. He did really easy, went to complete the hematological response, and then he was tolerating well the drug. As you can see, I did the PCRs were coming back, were going down until September. You can see at 3 months, at 3 months, he was 1.33% PCR. In September, he was already having a molecular response. And then at December, he starts having diarrhea. He's a doctor, so he doesn't come as often as I would like, and he doesn't consult, so he starts having diarrhea. He's in the OR, he's very uncomfortable with that, so he decided not to take the medication and doesn't come to me until January, where he lost his molecular response. He says he definitely can operate on this, he don't tolerate. So I tried to we did stop the medication for a while and start again, and he eventually decided he won't tolerate this medication. He tried with different doses, and he didn't respond. He didn't tolerate the medication. Well, the first question here is when to quit. In this case, it was difficult because he's a doctor and he's not willing to. I tried to lower the dose to 75, and he still had a lot of diarrhea. So that's the first question. How do you manage diarrhea in this patient? Have you seen it a lot? And when do you, because it's easier when it's hematological toxicity to measure, because but it's when it's subjective as this one. Will you just lower those, and how do you manage that type of toxicity?
I think one question, I guess it's interesting to me, and maybe I may have not heard it, but it sounds like the diarrhea started like 6 months after he started
Yes.
on the dasatinib, which seems a bit odd. I mean, not to say it's not possible, but usually those sorts of side effects happen kind of right at the start, if they're going to happen. So it just kind of makes me wonder if there was another concomitant med that may have been added, that may have been contributing to this, or if there was, I don't know how significant of a change in diet he may have had or something, but it just makes me question if there was something else going on at the same time. Because why wasn't he having any diarrhea for the first 6 months on the drug, and then all of a sudden it was so significant that he couldn't take it anymore, even on a reduced dose? Because again, oftentimes it's the symptoms or side effects like diarrhea, and I'm generalizing here, but if you're on 100 milligrams of dasatinib and you lower the dose, even if it doesn't go away completely, you should see some improvement in side effects. So if he didn't have any improvement in his diarrhea, it does make me question whether it was truly from the dasatinib. I don't know if Vamsi, you have a different opinion there.
No, I think that's well taken. I'm surprised too, like you are, with the diarrhea coming on late. Most of these drugs, the diarrhea, GI side effects especially, come on pretty quick. And quite often they get used to it later on. But this patient, unfortunately, is the other way around. Looks like, he tolerated well initially and then comes on with this diarrheal episode. And I think the diarrhea, as Kendra was saying, the diarrhea appears to be very dose related. So I would have done the same thing as you did, try to drop the doses, but maybe one thought would have been to drop it even further, because even at 50 or sometimes even lower than that, especially at a dose for somebody who with 6 months has responded and is below MMR by 6 months, maybe I would have tried to lower even further and see if that's something that they can tolerate and have a response. looks like this patient has a lot of other comorbid conditions, which may be a bigger problem on top of the CML that he has now.
Yeah, well, that's I was equally surprised. I sent him to the GI doctor, and he did a colonoscopy, and everything was right. And well, I didn't. You're right. I could lower the dose more than that, but he was only 6 months in the treatment, so I was afraid to lower the dose more than 75. I didn't, feel comfortable with that.
Yeah.
So then we're going to decide we're going to do, remembering he has multiple cardiovascular issues, portal thrombosis, cardiomyopathy, degeneration, and cirrhosis. The cirrhosis is always, it's not, he has a child A, if something, but the pathologist is not sure. He had a fibro test, and he was starting at least the next one. So remember, he's taking aspirin, Xarelto, and metformin next.
And did the metformin dose change? Because that's known to cause diarrhea. I wonder if any dosing changes there may have worsened it.
No, there was no change in anything. It was just, and well, he was, it is difficult because he's a doctor, so he's very, mind into it. There's no one to convince him that this is not the medication.
Sure.
So that's also a problem there.
Yeah.
So because he says, no, I took the azatinib and I'm better, and then this is the azatinib, there's nothing to convince him. So, and with these patients, the ideas they have makes it difficult. So we were faced with changing the medication between cardiovascular events and gastrointestinal toxicity and liver toxicity. So we had, and also the patient preferences. He's not willing to have any GI side effects. He operates all day. So we talked about it, and we had to consider bosutinib, which has been related with GI adverse events and hepatic toxicity, or we could change to nilotinib or ponatinib. Ponatinib, I thought it's too risky, so after talking with him, and this is a discussion I want you to have, and what's your opinion on that between those three options? Well, he had very good response, so that's what your choice will be in this case.
I think the patient, unfortunately is trying to tell us what he wants. He's not giving many choices, because if he says absolutely no GI side effects, imatinib has about 30 to 40% incidence of diarrhea too, although lesser than bosutinib. Bosutinib has about 80%, but and of course I agree with the ponatinib certainly is not a good option with somebody with these many comorbid conditions that are a high risk. And so we are left with only the nilotinib, because if imatinib and not trying the dasatinib even at a lower doses because of his own preference, and bosutinib are out, and ponatinib is a risk because of his comorbid conditions, I think we are left with nilotinib probably would be the only option for us, I think. Of course, I would be concerned with the comorbid conditions, but I think that's again where we can maybe dose reduce and see with time once he has a good response.
Yeah. Yeah, I mean, nilotinib always makes me a little uncomfortable in someone with cardiovascular history and diabetes. That's, I guess I don't know how well controlled it is, but at the same time, he is kind of dictating his own care. And I mean, if things like Imodium haven't worked and Metamucil and that kind of supportive care stuff hasn't worked to control the diarrhea with dasatinib, I mean, obviously he's going to be resistant to trying bosutinib, which is known for diarrhea. Although, I think it can certainly be short-lived in many people, but I can't imagine that he would even be willing to try it. and just based on what you've said about this patient, I wouldn't go with ponatinib in a patient like this either. So I think nilotinib, probably trying maybe a lower dose of nilotinib if possible. If the response is decent, because he's responded beautifully, like his PCR responded beautifully. So perhaps a lower dose of nilotinib would be sufficient, and maybe minimizing some of the cardiovascular risk.
Yeah, I think the first one with diarrhea around 6 months, that fits more probably with what we commonly see, some alternative diagnosis that can explain, although obviously every patient is different and can happen at any time, but that fits better. And I think ponatinib switch is good. I think the second question, Kendra, unilateral deafness.
I've never seen that.
Yeah, I've seen more with one with presentation of the disease, but not with the treatment. So that's unusual again there. But again, I wonder if there is any comorbid, any concomitant medication sometimes that could have interacted, or any other health conditions that can help us look for an alternate diagnosis. And maybe there is an interaction with dasatinib and another medication that's causing that. That's something to consider.
Yeah. Yeah, I mean, obviously, I'm sure the patient had imaging of their brain and nothing else was picked up, but I personally, I've never seen that as a toxicity or heard of that as a toxicity. I feel like that must have been some concomitant drug that maybe contributed, or maybe an unrelated event. I'd be curious what ENT had to say about that.
Well, this is the case. As you can imagine, I started on nilotinib, and I started with the full dose, thinking about doing a profound response, and even trying to take out the medicine early to TFR at that moment, because he had a very good response and he has all these comorbidities. So I don't want him to have the TKIs, too long. It's gonna take 5 years anyway, but as soon as I can take him out of this, I would like to do it. Well, in March 2022, his brother had a portal vein thrombosis. So this guy surely must have some thrombophilia, familiar thrombophilia. I was going to ask you if you take into account thrombophilia as to choose in any way TKIs.
It would again make me hesitant with ponatinib. I don't know about nilotinib. I mean, so far it sounds like he's doing okay. I don't know. But definitely ponatinib in a guy who's had thrombotic events and now has, potentially a familial condition, I would try to steer away from it.
Yeah. Well, and this is him. And as we expected, he had a very good response to nilotinib. This is his last PCR, and he's doing perfectly well. And expecting to do TFR as soon as we can. And well, working a lot of in his health style, and to have a healthy lifestyle, weight loss, and control of his diabetes. So I think that's my first case there.
So any further comments and questions on Virginia's case? Soledad, you have your hand up.
Yes, I would comment first that maybe in this case, as the patient has so many comorbidities, maybe now that he's in a molecular response, maybe it would be a good idea to lower the dose in order to diminish the damage if he is all these conditions. That is one question or suggestion, whatever you wish. And the other point is that I have a patient that after many months, it was more than 6 months, she started on a diarrhea. she was on dasatinib third line. And after, well, I tried to treat the diarrhea with all what you have mentioned. And after a few months, she was diagnosed as ulcerous colitis. And after stopping dasatinib, everything was resolved. And she came back to normal in her gastrointestinal condition. So it is rare, but I think that it can happen. What do you have any comment on that?
I mean, I think that. Go ahead, Virginia.
No. I was asking. I was going to comment that what do you prefer? You stay in a high dose to achieve rapidly a profound response, or you lower the dose to try to diminish the toxicities?
Is this patient, is he experiencing side effects from the nilotinib?
No.
Personally, I don't know how others feel. I don't know really what the right answer to this is. My personal approach would probably be to lower the dose because his response has been extremely good, and I would anticipate that it could probably be maintained. And I mean, yeah, and at least based on the NCCN recommendations, I know ELN is a little stricter, but based on NCCN recommendations, he has just 1 year left before he could attempt to discontinue treatment. And so I think if you lowered it to either 300 BID or 400 daily, and you could see how he does, and potentially decrease some of the cardiovascular risk, that to me would make sense. But I mean, by the book, what he's on is exactly what he's supposed to be on.
So I think in the interest of time, we're going to have to move on. This always happens, doesn't it? Such a rich discussion. We can come back to these matters later. And also, it might be a good opportunity to mention our case discussion forum on our website, where physicians come with difficult or interesting cases or particular questions, list them. We can find the best experts in the world to comment on them. I'll show you where to go for that later if you aren't already involved in that, but we have a case discussion forum for exactly these kind of conversations.